Do you know what I mean? So it depends on the situation yourselves. We can start off doing a little release. I'm just going to bash through this stuff fairly quickly, the soft tissue, because you've been doing it for about 2.5 years at this point. If you haven't got it by now, we're in the shits, right? So your little suboccipital release. Again, in your exam, you should take your time doing it. Yeah, you can work through your posterior cervicals, all that kind of stuff, and be dragging through your posterior cervicals. While you're doing that, you can hop in and do that little wave technique. What I'd say with this, it's like a PA, isn't it? It's like a PA in a supine position, which is quite handy. You can do it in neutral or a little bit of rotation or whatever you want to do, whatever you think is handy for the patient. Engage it with this hand. So you can engage it with these fingers. Then you're going to use these fingers as a passive lever, and you're going to push with the other hand. And I like to treat along the treatment plane, so you're kind of pushing up towards the patient's eye for that lower cervical spine. What I'd say is this: don't be kind of bouncing the patient that way. Engage the barrier, and then do a kind of gentle, progressive oscillation. But there's a little bit of pressure to it, but it's not fully releasing and bouncing the patient around, because that's not nice, is it? Okay. So engage the barrier and then mobilize the barrier as you would with a PA. That's what I'd recommend for that. So you can intersperse that with your soft tissue. You don't have to just do soft tissue first, then this. You can intersperse it all around, let it flow together. Next off, we can do our nice scom release. This guy's got a tightness and soreness in the scom, so we can release that out there. Warming it up first, from deep to, or from superficial to deep, along the length of the scom. And then we can get it to a little pin and a gentle little stretch. Now he's had his injury for about 2 weeks, 3 weeks, so he's into 21 days of healing on that muscle. So you're not going to damage the muscle healing. If it's an early stage, if you'd had it yesterday, it'd probably be a bad idea to start pulling the scar apart. But if he's had it for a few weeks, if we want to modify that soft tissue, there's probably no harm at all. And putting a little stretch. So again, you're going to pin it and just rotate the head down. Can you feel a little stretch there in your scom, Julie? Lovely. Now, if you had a VBI, could we do that? Well, let's have a look. If you can visualize Julie's VBI there, do a little CSI, visualize it on the left hand side. Are we doing loads of rotation there? No. Can you feel the stretch? Right, we're not doing loads of rotation. So you can kind of pin it like that and do that little stretch along there. That won't cause a big problem for someone, yeah? Even the VBI. We can do some kneading into the scalenes. If you've got a little moisturizer, you can strip down through it that way, but just using that aspect of your fingers there, and just loose kind of grip. Is that really sore? Are you okay? You know, if it's really tight, if you feel there's low tension there, shorten the muscle up a little bit so you can knead in through the tissues a little bit easier. Okay, so we can do that work there. Is familiar enough with that stuff? Okay, let's say he's got a bit of tightness and pecs. In fact, mind if we do that? Okay, good. So we can release out in there a little bit. Sorry, do you grab your pecs? Okay. Some pins and stretches that way for the pec minor, that kind of stuff. Putting a huge amount of tension on the brachial plexus when he's got a nerve root issue, that'd be a great idea. Maybe not early doors, no. But we can take it easy around that then and come back to the traps. And you get into the later attachment a little bit this way. And nice and convenient without moving the patient around or irritating them too much. You can get a decent bit of soft tissue work done. How you feeling there? You okay? You've got a few more techniques from there, haven't you? Charlie does that. Once you do that, once you do that, release there, that kind of stuff on this guy. Any of those techniques, put them in there. In between all that, I have no problem. With this guy, you could either do this kind of opener here, which is your phase 1 dynamic opener type of thing. Yeah, the kind of second phase, we do a bit of flexion, a bit of side bending, a bit of rotation, and you do that translation through that way. To open them, create a little bit of a pumping effect around the foramen there. Now again, when you think of the openers, think about the foramen and the nerve root. Don't worry about what's happening in the joint and all that. Foramen, nerve root, that's what you're thinking about, where you're trying to create your physiological response. Whether it does or not is a moot point, but that's what you're trying to do, theoretically. Okay, so like so. If you wanted to do your static opener, so we'll just go through that opener sequence, yeah? For you. So the static opener, you're going to get your other towels nearby, so you can grab me a towel there when you're ready. A little bit of flexion, how's that there? A little bit of side bending, a little bit of rotation.
A little pillow there if you want that.
Yeah, that's very well, lovely, thanks very much. Don't mind that you just a little biohazard pillow behind you. So a good bit of flexion on each, yeah, so a good bit of flexion, side bending, rotation. What 2 questions do I need to find out? What 2 things do we need to find out from Julie now? Is it centralizing or is it peripheralizing worse? And then, is the pain more intense or less intense? Those two things. If it's less intense or if it's centralizing, then the technique is indicated. We do it for 2 minutes, give it a little rest, do a bit more soft tissue, then come back and do another 2 minutes. When they've done it for the first time in the clinic, and it got on okay, no big nasty reactions, no sensitization afterwards, we can get them back in and get them to do it at home then if that helps. Okay, if it's a helpful position for them, we can give it as a home care exercise. So that's a static one. Dynamic one, you're going to do seated, like so, and you're going to use your forearms like a fulcrum on the corner of the table to bring it to the place. So I drop my elbows, head movement deflection, side bending, rotation, and we do that little translation through, pushing through, just like that, pushing through. Try and localize in a little bit as well. Flexion, side bending, and rotation. And for the last one, we'll ditch the rotation because it's too awkward. For the big opener, was a less acute, less severe type of case, hop into this chin hold and we do flexion, and then we do this decent sized side bending here. What's happening at the foramen there?
Pumping action.
Opening. So now we get into the nerve mobilizing.
Fulcrum on that side, is it?
Yeah, bring a little fulcrum there, yeah, but I'm not going to end the range and bashing that. I'm just trying to create that big pumping effect to the opening, closing of that foramen. Could you slide up to me a little more? Put your head off the top of the table. Now, the thing to get straight in your head is, that's not that gapping technique for the joints. That's in a whole separate box. You understand? As long as you're clear on that, you won't run into any problems. Simple. So, the lateral glide technique, again, everything from neck pain, nerve root problems to tennis elbows, that kind of stuff this has been used for in various pieces of research. You're going to stabilize the shoulder, patient crown of the head off the top of the table. Let the crown of the head sit into your iliac fossa, and your hand here is going to grab whatever segment you're at, you're going to grab the upper one. So for C5 to 6, you grab C5, like that. It's going to sit in there like SP, lateral, articular pillar, like that, and you're just going to pull across. So your whole body's going to move across to translate head and neck that way. Do I want to jam the shoulder into depression to get as much tension on that as possible? No, just hold it there. And relax your head as much as you can, Julie. That's perfect. Right.
So are you putting pressure in both directions, or?
I'm really pulling this way, but
Because you're trying to open the left one.
not trying. This is not about opening anything. This
Okay.
is basically about this. I'm holding the nerves in place, and I'm sliding the foramen in relation to the nerves. Think of it that
So
way.
you're holding the nerves on her right arm.
Yeah, when I'm holding her arm there, I'm holding the whole
You're
plexus.
stable. Okay. Yeah.
Pretty much, yeah. So,
So it's okay.
and then we're sliding the plexus. So we're sliding the nerves in relation to their mechanical
Okay.
interface.
Okay. So you're not individually looking at the.
Opening the frames or anything.
Yeah.
No,
Okay.
no.
Okay. It's a general.
So simple like that. And the head should make that goofy looking. She's doing there. Perfect. Do that. They can see it anyway. It doesn't matter. Okay. And another way of doing that again is using the arm, and we'll just leave it at this for the upper linear dynamics. Elevation, depression of the arm. Simple like that. That's going to cause some movement up here. We can use a radially loaded position for this guy. No reason why not. As long as I'm not kind of yanking out of it too much. And just a very gentle way to mobilize the nervous system in that area there. Or the median nerve load position, let's say. Okay. Again, if you're doing the lateral glide, you can have the arm either here, 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 any of those loaded positions. Get the idea? Bada bing. That's all you need to know for this exam. We'll come back at the old upper limb urodynamics in the next section.
Should we do the upper limb tension tests? Should we have those?
Know the tests. Know the tests. You can do them the way you learned in the second year, the way we did them the last weekends. Your call. As long as the patient gets into the right position, I don't care. I know both ways you've been taught them and all that. So as long as they end up in the right place and you interpret the test correctly, I don't care. Your call how you get in there and how you control patients.
And for this case that we were just doing, would you have done upper limb tension tests for him?
Well, it's kind of, for me with that guy, it kind of looks like it is what it is, right?
Spurning's positive.
To really confirm how sore it is, I could have done. Did I need to? Exactly. Spurning's positive.
Yeah.
Everything fit. The neurodynamic, or the the myotome test was positive, or sorry, the dermatome test was positive, the myotome test was
that
negative.
would be overkill in terms of testing, really.
For me, yeah, it could be overkill. Now, would I say, oh no, that's really bad what you've done there? If you had about 6 more tests on top of that again, I'd be okay, that's just torture at that point. That's like having grave, like, but, you know, up until that you can't.